Hi, I'm Dr. Jennifer Shuford. I'm an infectious disease specialist, and this lecture is on antivirals, specifically antiretrovirals, those antivirals used against HIV infection. Let's begin with an overview of HIV infection and HIV treatment. HIV is unlike other infections that we've discussed in previous lectures. HIV has an acute phase. You can have acute retroviral syndrome right when you're infected, lasts 3 to 6 weeks, and is a mononucleosis-like syndrome. But then the body seems to recover. Right when that HIV infection begins, the viral load goes really high, the CD4 count may drop, but then things normalize again. But over the course of about 10 years, AIDS will develop. And so from that first point of HIV, you see that the cells are infected, you have HIV replication, and slowly but surely it destroys the immune system until finally you get to that end stage HIV point where you develop AIDS. So it begs the question, when do we start therapy? And there are Department of Health and Human Services guidelines for the United States that say when somebody has a CD4 count somewhere between 200 and 350 cells, that's a good time to begin therapy. And most experts would agree that 350 cells, CD4 count of about 350 is a good place to begin therapy. But why do we even delay that long? We saw in our last lecture, our last antiviral lecture about influenza, that we needed to start that drug within 48 hours of symptoms or we don't get any sort of effect better than placebo. But here we're waiting years before we start therapy. One of the reasons is that we have limited drugs. We have 5 classes of drugs that we'll be talking about today. So we don't have an extensive array of drugs. This is a chronic, lifelong infection for which a person will have to take medications every day for the rest of their life. These drugs have significant toxicities associated with them, and a person's HIV strain can become resistant to these medicines. So there's many factors that we have to balance here. And if a person needs to be on them every day for the rest of their life, and compliance is of utmost importance so that we don't have an increased rate of mutations, then it's important to wait until that patient is ready to take that medicine and ready to begin that therapy. And so we're trying to maximize the benefit of the therapy and minimize the consequences of the therapy. And so there's a real strategy that goes on behind the scenes of figuring out when is really the best time to start HIV therapy. And really this wasn't even a question before 1987, because before then we just had to deal with the opportunistic infections of end-stage HIV or AIDS. In 1987, the first antiretroviral was approved, and that's zidovudine, or AZT. And now we have described the whole HIV life cycle and are able to target different processes within that life cycle to control the infection. So how do we control the HIV infection? We've developed a strategy called HAART, Highly Active Antiretroviral Therapy, HAART. And this is a combination of antiretrovirals that is meant to suppress viral replication and restore the immune system. So if we're combining antiretrovirals, what are we combining here? Well, there's 5 classes of antiretrovirals that target 4 different viral processes. And these 5 classes of antiretrovirals include the NRTIs, which are nucleoside or nucleotide reverse transcriptase inhibitors. We have the NNRTIs, the non-nucleoside reverse transcriptase inhibitors, the protease inhibitors, entry inhibitors, and integrase inhibitors. First-line therapy for HIV usually involves 2 NRTIs and 1 NNRTI or 1 PI. And so every patient will have what we call an NRTI backbone. So 2 drugs of the NRTI class, and then we'll add at least 1 other drug to it, and that's usually either an NNRTI or a protease inhibitor. So how do we make our therapeutic selections? The therapeutic selections for the HIV patients that we put on antiretroviral therapy are based on Number one, avoiding the use of two agents of the same nucleoside analog. We don't want competition between two of the drugs that we're administering, so we don't give two agents of the same nucleoside analog. Number two, avoiding overlapping toxicities and genotypic or phenotypic characteristics of the virus. Number three, we optimize therapy for an individual patient, and that means taking into consideration their comorbidities and the symptoms that they experience with these different classes of medications. Number four, minimizing drug interactions, and that's between the HIV medications themselves as well as other medications that they might be taking for comorbid conditions. And fifth, maximizing the ease of therapy for a given patient. As I mentioned, this is lifelong therapy. Once a patient begins on HIV therapy, they usually take it every day for the rest of their life. That's as the medical situation stands now, and we're hoping for some great advances in this field. But for now, it means taking medicine every day for the rest of your life. And because that's a pretty tall order, we're trying our best to maximize the ease of this therapy for any given patient. And some patients, they like to take medicine right when they wake up. Some people like to take it with food. Some people like to take it once a day. Some people don't mind taking it twice a day. And so for any given person, we try to match their therapy with their individual characteristics. Our therapeutic goals include suppressing the viral load, and that means a durable suppression. So a suppression of the viral load that lasts a long time. And by suppressing the viral load, what I mean is we can do a blood test. We can check the blood and see how many viral copies we can see in the blood in 1 milliliter of blood. And viral copies, I mean HIV copies. We'd like to get it less than 50 copies. And so by suppressing the viral load, I mean getting it less than 50 copies per milliliter. We try to restore and preserve immune function. The way that we can best measure this is by the CD4 count. We can watch it go down, we can watch it go back up, and this does correlate with the strength of the immune system. It's not the whole story, but it's a good indicator that we can easily measure in lab tests. We want to reduce HIV-related morbidity and mortality. And lastly, just to improve the quality of life of HIV-infected individuals. In the event that we are on therapy and the viral load is suppressed to less than 50, but over time we may see that viral load climb. Sometimes we'll just see a little, what we call a blip. It'll go up and then it'll come back down, and it's not of much concern. Occasionally we'll see a gradual climb in a viral load, and we'll suspect that there's a mutation there that's making them resistant to at least one of their drugs. In that case, what we'll do is usually check a genotype. That means is that we'll send in a sample of blood that has HIV in it, and then we check the genes on that HIV virus that we've just submitted and look for mutations. Specifically, we look for mutations that confer resistance to our HIV medications. And with those listed mutations, we can see which antivirals would work best for this person, or at least you can see which antivirals wouldn't work best for the person. And then we try to put together a regimen that would work against the HIV virus that they are experiencing predominantly in their system. For recommended first treatment, like I said, we usually try to use at least 2 NNRTIs and 1 protease inhibitor or 1 NRTI. And now what we're going to do is we'll go through each of these agents individually by class, and we'll talk about their individual characteristics, including side effects, which can be significant. So let's begin now with NRTIs, and that's nucleoside or nucleotide reverse transcriptase inhibitors. And first, let's talk about their mechanism of action. NRTIs are analogs of native ribosides, and these are nucleotides or nucleosides that contain ribose. When they enter the cell, they are phosphorylated and then inserted into the viral DNA by reverse transcriptase. The NRTI does not have a 3' hydroxyl group to allow the formation of a 3' 5' phosphodiester bond within the growing DNA chain, and so that elongation phase is terminated. These NRTIs are fairly specific for HIV reverse transcriptase. However, human mitochondrial DNA polymerase gamma appears to be vulnerable to NRTIs at therapeutic concentrations, and this is the basis for many of the side effects that we see with the NRTI class. Let's talk a little bit about their pharmacokinetics. Most NRTIs are primarily renally excreted, and they need dose adjustments for renal insufficiency. Abacavir is the exception. It's metabolized through alcohol dehydrogenase and glucuronol transferase. The adverse effects of NRTIs, many of the adverse effects, like I mentioned, are thought to be secondary to the NRTI's effect on mitochondrial DNA polymerase. The dideoxynucleosides, which include didanosine, stabudine, and zalcitabine, all have greater affinity for the mitochondrial DNA polymerase. And so these drugs, didanosine, stabudine, and zalcitabine, are all associated with peripheral neuropathies, pancreatitis, and lipoatrophy. And what lipoatrophy is it's actually a fat redistribution. And so we'll see in patients who are on NRTIs, and especially who are on these 3 NRTIs, will have a fat redistribution where the fat goes from their extremities to their central location. And so they'll start to lose fat on their arms. And what you'll see is more muscle definition, you'll see veins popping up, and it'll look like they're actively working out all the time. And this will be on the arms and the legs, but then they'll also start to get a pot belly. They can get a buffalo hump. And so you just see this centripetal redistribution of fat. The other place that they lose it is on their face, right here underneath the cheekbones especially. This can be really troublesome. It's a physical stigma of being treated for HIV, and many people will recognize this, the outward appearance of HIV therapy, and so it can be really disturbing to patients who are on HIV therapy. All NRTIs have been associated with life-threatening hepatotoxicity, which is characterized by lactic acidosis and hepatomegaly with steatosis. And so there we see fat deposition actually into the liver as well. And so care should be taken to choose NRTIs that do not have overlapping toxicities as best as we can. Some of these are a class effect, and we have to combine NRTIs, and so we can't always avoid overlapping toxicities, but when we can, we try to avoid those. Drug interactions. Because these drugs generally undergo renal excretion and are not metabolized, there are really very few worrisome drug-drug interactions. Zidovudine and tenofovir are exceptions, and these will be discussed in a few minutes. And resistance. NRTI resistance is well characterized. One of the best known mutations is at codon 184. The mutation is called M184V. And this imparts resistance to lamivudine, but partially restores sensitivity to zidovudine and tenofovir. And so these mutations don't always just have clean interactions with the drugs. And so here we see that the same mutation will make it resistant to lamivudine, but make it more sensitive to zidovudine. So it can be slightly complicated to interpret these genotypes. Cross-resistance and antagonism are problematic for agents within the same analog class. So if they're thymidine analogs, cytosine analogs, guanosine or adenosine analogs, when they're in that same analog class, you're going to see more antagonism and cross-resistance. So using agents from the same analog class is contraindicated. So for instance, you shouldn't use zidovudine, which is AZT, with stabudine, which is D4T, because they're both thymidine analogs. So we will begin discussing the NRTI therapies with zidovudine. Zidovudine is also called AZT. And so as we go through these NRTIs, you're going to realize they all have these 3-letter abbreviations, as well as their true generic name, which can be very confusing. When I was starting my fellowship in infectious diseases, I just had to make flashcards for myself because it was so ridiculously confusing. And so I'll try to make it clear as I go through and not confuse you with all the different names that each of these drugs can have. But zidovudine is called AZT. It is approved for use in children and adults. It's recommended for routine therapy in the perinatal period to block the mother-to-child transmission. And so zidovudine is used as part of combination therapy for the mom. It can be used as single agent for the mom in emergencies and also for the baby after they're born. So it's still very useful a drug, even though it was the first approved HIV drug in the United States. AZT can also be used for prophylaxis of HIV after a known or suspected HIV exposure. Zidovudine or AZT is well absorbed through oral administration. The half-life is about 1 hour in the serum, but it's about 3 hours intracellularly. It achieves excellent penetration of the blood-brain barrier. Adverse effects for AZT include headache and bone marrow toxicity. And we've mentioned it several times in previous lectures that zidovudine is a drug that causes bone marrow toxicity. So if you're using it with other agents that cause bone marrow toxicity, it may have more than an additive response with these overlapping toxicities. So you just have to be aware that AZT can cause bone marrow toxicity, and you should limit other drugs that have this same side effect. Drug interactions may be an important consideration with zidovudine. Because zidovudine is glucuronylated by the liver prior to excretion, drugs that slow the glucuronylation process will increase the concentration of zidovudine and therefore its toxicities. These drugs include probenecid, acetaminophen, lorazepam, indomethacin, and cimetidine. Both stavudine and ribavirin are activated through the same intracellular pathways and should be avoided with zidovudine. All right, let's move on to the next NRTI agent. We'll talk about stavudine, which is D4T. Stavudine is a thymidine analog, just like zidovudine or AZT. It's a strong inhibitor of intracellular enzymes such as the beta and gamma DNA polymerases, and therefore they do affect mitochondrial DNA synthesis, which results in toxicities to humans. Stavudine is almost completely absorbed orally with or without food. It does penetrate the blood-brain barrier, which is good because HIV penetrates the blood-brain barrier and we find it in the brain. So agents that get in there and can treat the HIV, they are very beneficial. Doses need to be adjusted for renal insufficiency. And major adverse effects with stavudine include peripheral neuropathy, fat redistribution, and hyperlipidemia. Let's move to the next NRTI now, and this one's called didanosine. It's also known as DDI. Didanosine was the second drug approved for use in HIV/AIDS in the United States. It's also called DDI, dideoxyinosine, because it's missing both the 2' and the 3' hydroxyl groups. Upon entry to the host cell, DDI is transformed to dideoxyadenosine triphosphate, or DDATP, which is incorporated into the DNA chain and causes DNA chain termination. Absorption for DDI is best in the fasting state. The drug penetrates the blood-brain barrier less efficiently than zidovudine does. About 55% of the parent drug can be found in the urine, and since we're relying on the kidneys to excrete that parent drug, we do need to reduce the dose if there's renal insufficiency. Toxicities for DDI include pancreatitis, which can be fatal, and peripheral neuropathy. And I've definitely had test questions about the link between didanosine and pancreatitis, so remember that association. Adverse effects closely mirror stavudine, and so the two should not be used concurrently. Both of these agents have a significant number of adverse effects and severe adverse effects compared with other NRTI agents, but both of them are still potent drugs. And so we do resort to using these still sometimes in people who have multiple mutations, but they aren't first-line agents because of the severity of their adverse effects. Tenofovir. Now, tenofovir is also called TDF, but most of the time people still call it tenofovir. Tenofovir was the first approved nucleotide analog. It's converted from a monophosphate to a diphosphate form within the host cell and then inhibits HIV reverse transcriptase. Cross-resistance with other NRTIs may still occur. Some zidovudine-resistant strains do remain susceptible to tenofovir. Tenofovir should be taken with a meal to increase bioavailability. In general, it has a long half-life, and this is wonderful because it means that we can give tenofovir once daily. Most of the drug appears unchanged in the urine, secondary to both filtration and active secretion, and the dose must be adjusted for renal insufficiency. GI symptoms are frequent with tenofovir, and they include nausea, vomiting, and diarrhea. And drug interactions are a problem for tenofovir, unlike many of the other NRTIs. So remember, we said drug interactions were important for zidovudine, or AZT, as well as tenofovir. Tenofovir can increase the concentrations of DDI, and it can decrease the concentrations of atazanavir, requiring that atazanavir be boosted by ritonavir if you choose to use atazanavir with tenofovir. And because both of these are once daily drugs, they often are used in combination, and so this is an interaction that you need to be concerned about. Let's move on to the next NRTI agent. We'll talk about lamivudine. Lamivudine is also called 3TC. Lamivudine can be used in combination with zidovudine or AZT, and it very often is. There's a co-formulation of lamivudine and zidovudine, which has been used successfully for years. Lamivudine should not be used in combination with cytosine analogs because of antagonism. Lamivudine is 3TC, so you might guess that that's a cytosine analog, and so it shouldn't be used with other cytosine analogs. Lamivudine terminates proviral DNA chains and inhibits reverse transcriptase for both HIV and HBV. So you may remember that both tenofovir and lamivudine were discussed in the hepatitis B antiviral lecture. And so both of those drugs are also active against HIV and are used routinely for the treatment of HIV. Lamivudine does not have a significant effect on mitochondrial DNA or on bone marrow precursor cells. It has good oral bioavailability and is generally well tolerated. It's a good drug for the treatment of HIV. It does undergo renal excretion, so it requires dose adjustment for renal insufficiency. There are some side effects that you should be concerned about. It can cause headache, nausea, diarrhea, and rash, as well as other NRTI class effects that we see repeating through all of these NRTIs. Lamivudine, however, is dosed twice daily, and so it's somewhat less attractive than the NRTIs that can now be dosed once daily. And we'll talk about one of those right now. Emtricitabine is also called FTC. So emtricitabine is a fluoroderivative of lamivudine. It inhibits both HIV and HBV reverse transcriptase, and it appears to be at least as effective as lamivudine. It has good bioavailability, and the plasma half-life is about 10 hours, and the intracellular half-life is about 39 hours. So this one can be dosed once daily. Since it's a derivative of lamivudine, you'd expect a lot of these same properties with emtricitabine, and that's what we get, just with a longer half-life. It is eliminated essentially unchanged in the urine, and so it doesn't have a lot of cytochrome P450 interactions and very few other drug-drug interactions. Like lamivudine, emtricitabine is well tolerated. It has the same side effects of headache, nausea, diarrhea, and rash, and the same class effects of NRTI, such as lactic acidosis and hepatomegaly with steatosis. There's also some associated hyperpigmentation of the palms and soles, which are associated with emtricitabine that you might not see with the other agents. Okay, let's move along to zalcitabine. Zalcitabine is also known as DDC, and so as you might guess, this is a cytosine analog. This was the first cytosine analog that was available, but zalcitabine had a lot of severe toxicities associated with it, so it's been removed from the market. The next agent we'll talk about is abacavir. Abacavir is sometimes called ABC. And don't let that C fool you. It's not a cytosine analog. It's a guanosine analog, but ABC, it has a certain ring to it, and it's short for abacavir. Like I said, it's a guanosine analog, and there is some cross-resistance issues with zidovudine and with lamivudine. It is well absorbed orally. Metabolites appear in the urine, but cytochrome P450 system does not appear to be involved in that metabolism. The ABC dose or abacavir dose does not need to be adjusted for renal function. Adverse effects include headache, dizziness, and GI symptoms. The big side effect that you need to remember with abacavir is hypersensitivity, a hypersensitivity reaction. About 5% of patients who start abacavir will develop a hypersensitivity reaction that always includes drug fever, but then also includes at least one of the following: rash, GI symptoms, malaise, or respiratory distress. The important thing to remember about the abacavir hypersensitivity reaction is that once they have this reaction, they should never be rechallenged with the medication. Being rechallenged with that medicine can lead to fatal reactions. And so it can cause death in a patient if you rechallenge them with abacavir once they've already had a sensitivity reaction. Thankfully, there is a new HLA test that can screen for patients who will potentially have this hypersensitivity reaction. And so this test is indicated before you initiate abacavir therapy. And that's a new development. So that's an interesting and good development in the field of HIV. Okay, so that concludes the NRTI class discussion.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
And since I'm right again, I will take adverse effects for 600.
This drug's adverse effects include prolonged PR interval, benign hyperbilirubinemia, and jaundice. Abby?
What is atazanavir?
Correct.
Good job, Abster. But did you really have to bring a nurse with you?
I'm not a nurse, thank you. My buzzer's just broken.
Antiviral therapies for 1,000.
Oh, trying to catch up with me, are you? Well, I wouldn't let you play with me if I wanted to lose.
Let us? You stole our charts and ran away.
Potato, potato.
Darunavir, enfuvirtide, and tipranavir are drugs involved with these HIV therapies.
I'm going to stand here and give you one more moment to try to figure it out. Beep! Oh. That's what I thought. What is salvage regimens?
Oh, I knew that!
Yeah, well, I know it.
Beep! Can I go now?
Were you even here?
Rematch, houseless. Next time you're going down.
She took my house.
So let's review the answers to quick review number one. Number one, which NRTIs have the greatest affinity for human mitochondrial DNA polymerase gamma? These are stavudine, didanosine, and zalcitabine. Number two, what main adverse effects are associated with the drugs in the above question? So the effect of having that affinity for human mitochondrial DNA polymerase gamma is peripheral neuropathy, pancreatitis, lipoatrophy, and hepatotoxicity, which includes lactic acidosis, and hepatomegaly with hepatic steatosis. And if you're not familiar with that term hepatic steatosis, another way that's described is simply fatty liver. So hepatic steatosis is fatty liver. Number three, which NRTI generally does not cause hepatotoxicity, and that's abacavir. Number four, which NRTI is associated with bone marrow toxicity? Definitely high yield. This is zidovudine. Number five, which NRTI is associated with hypersensitivity reaction? Also important to know, this is abacavir. Number six, how is the mechanism of action of NRTIs different from that of NNRTIs? So both categories of drugs inhibit reverse transcriptase, but the NRTIs do so by getting incorporated into the viral DNA. They are nucleosides. The NRTIs, the non-nucleosides, inhibit reverse transcriptase by binding directly to the reverse transcriptase enzyme. So it is important to know the distinctions and the mechanisms between the two drugs, although the end result is to inhibit the reverse transcriptase for both drug categories. Number seven, what is the main side effect you need to remember for NNRTIs? This is a rash. All right, so you need to know that rash is a class side effect of the NNRTIs, although some drugs are more likely to cause rash within this class than others. Number 8, which NRTI is known for causing rash and GI intolerance? This is the description of the hypersensitivity reaction that abacavir could cause. So this, again, is abacavir, and just know that that hypersensitivity reaction on a test may not always be described as hypersensitivity reaction. They might simply say rash and GI intolerance. So you need to be able to understand those interchangeably. That rash and GI intolerance is the hypersensitivity reaction of abacavir. And number 9, describe the clinical scenario when antiretroviral therapy would be indicated. So the quick and easy thing that Dr. Shuford mentioned is when the CD4 count is 350. If you remember no other rule, that's a good rule to remember. But let me just discuss some very distinct recommendations by the United States Department of Health and Human Services. So number 1, you definitely need to initiate antiviral therapy in a reliable patient, of course, if the patient has a history of AIDS-defining illness or severe symptoms of HIV infection, regardless of the CD4 count. You also need to definitely initiate antiretroviral therapy in patients when the CD4 count drops below 200. So 200 is one marker, another marker is 350, which brings us to the next point. You're supposed to offer patients the opportunity to go on to antiretroviral therapy if their T cells, if their CD4 cells are between 201 and 350. So again, as a general rule, 350 and below, it's a good idea. Definitely offer it if it's between 201 and 350. If it's less than 200, they really should be on it if they're reliable. The other scenario in which you should offer antiretroviral therapy to patients is when the HIV viral load, or the HIV RNA, is greater than 100,000 copies per ml, indicating a very rampant HIV infection, regardless of what the CD4 count is. And then one scenario, or two scenarios in which you should definitely defer treatment, is if the CD4 count is greater than 350 and the HIV RNA is less than 100,000 copies per ml. So, I'm sorry, one scenario, two criteria in which you should definitely defer treatment. If the CD4 is greater than 350 and the HIV viral load or HIV RNA is less than 100,000 copies per ml.
We're going to move on to the next class of HIV medications, and these are the NNRTIs. NNRTIs are highly selective, non-competitive inhibitors of HIV reverse transcriptase. By binding to the enzyme, they can cause a conformational change that inhibits the enzyme function. The major benefits of the NNRTIs include a lack of cross-resistance with the NRTIs and a lack of effect on blood cell formation, so they don't have bone marrow suppression. Unfortunately, the NNRTIs do have a lot of cross-resistance within their class. They have drug interactions and they have a significant number of hypersensitivity reactions, so they do have their own issues, but it's good to have this class of non-nucleoside reverse transcriptase inhibitors. We're going to begin discussing these NNRTIs individually. We will begin with the agent nevirapine. Nevirapine should be avoided in women with a CD4 count above 250 and in men with a CD4 count above 400 because of an increased risk of hepatotoxicity. Nevirapine is well absorbed orally, is not affected by food and antacid medications. Nevirapine is lipophilic in nature, which does contribute to its wide distribution throughout the body tissues, the central nervous system, a fetus, and in breast milk. Nevirapine is extensively metabolized through the CYP3A4 family of cytochrome P450, and it induces that CYP3A4. So by inducing one of these cytochrome P450 enzymes, it leads to decreased levels of oral contraceptives, some antiarrhythmics, oral anticoagulants, and methadone. The most frequent side effects that we see with nevirapine include rash, fever, headache, elevated liver enzymes, and actual hepatotoxicity. There can also be some severe dermatologic effects from nevirapine, and these include Stevens-Johnson syndrome and toxic epidermal necrolysis. A 2-week lead-in time of reduced dose can help with these epidermal effects of nevirapine. So what we do is we start at a reduced dose for 2 weeks, and then we titrate up to the normal continuation dose, and that's the dose they stay at. And by doing that kind of tapered approach, we see that there's fewer of these skin reactions. All right, let's move on to the next agent, and that's dolaverdine. Dolaverdine is not a preferred agent for the treatment of HIV, and actually it's rarely used clinically. It is rapidly absorbed after oral administration and can be taken without regard to food. It's extensively metabolized and is excreted through the urine and feces almost equally. It's a substrate for CYP3A4 as well as CYP2D6, and it's an inhibitor of both of these metabolic enzymes. And by inhibiting these enzymes, it actually increases levels of protease inhibitors. And unfortunately, other inhibitors or inducers of these enzymes may raise or lower plasma levels of dolaverdine. And so you need to be really careful about drug-drug interactions with dolaverdine, but that holds true for this class. And the most common side effect for dolaverdine is rash. Let's talk about the next agent in this class of NNRTIs, and that's efavirenz. Efavirenz is a great addition to our HIV therapy armamentarium. Efavirenz has demonstrated good clinical results with a durable suppression of the viral load and an increase in CD4 count that rivals the improvements that we see with protease inhibitor-based regimens. And for a while, people thought that protease inhibitor-based regimens were really the gold standard. That's where the money was, and that's the sort of potent and durable regimen that we should start patients on. But really, efavirenz has shown equal efficacy in trials. Therefore, efavirenz is one of the agents that's listed as first-line therapy in national guidelines for the treatment of HIV. And of course, this is always in combinations with that NRTI backbone that we discussed. Following oral administration, efavirenz distributes widely, including the CNS, and fatty meals can actually increase the bioavailability of efavirenz by up to 50%, so it's not recommended to do that. It is highly bound, with about 99% being bound to plasma albumin. The half-life is about 40 hours, and this is one of the best things about efavirenz, is that we can dose it once daily. And since we've got efavirenz that can be dosed once daily, emtricitabine that can be dosed once daily, and tenofovir that can be dosed once daily, there we've got a whole regimen of a once-daily medications that can be used for first-line treatment for HIV. Efavirenz is extensively metabolized and can act as an inducer of the cytochrome P450 isozymes. And this may reduce the plasma concentrations of other medications that are metabolized through that system, so you do have to be careful for drug-drug interactions. Adverse effects that we see with efavirenz include skin rash and CNS symptoms. Skin rash is very common, but usually we can treat through the skin rash. It's not like the skin rash that you see with abacavir that should scare you. Efavirenz is usually mild, and we can usually treat through it. If it's severe, you won't want to, but if it's mild, you can treat through it. The more important side effect that you need to remember for clinical application, and especially for your tests, are the CNS side effects of efavirenz. CNS effects are quite common, especially during the beginning of therapy, and they often subside over time, but they can be very disturbing to patients. They include vivid dreams, difficulty concentrating, dizziness, and headache. And so we try to minimize this, sometimes by just having people take their efavirenz at night before they go to bed, so they won't notice that dizziness and that difficulty concentrating as much, because they have most of those side effects while they sleep. But that can't always, it doesn't always work like that. However, that is one way that you can try to minimize these side effects. One really problematic things about efavirenz is that it can exacerbate underlying psychiatric illness if it's present. And so in patients that have had a history of depression, you need to be careful with efavirenz. And so it can exacerbate it. And in some cases, we have to withdraw efavirenz therapy because we can't get the psychiatric illnesses under control. And so that's a definite interaction that you need to, or a definite side effect that you need to remember about efavirenz. And efavirenz should be avoided in pregnant women. It's a class D, pregnancy class D medication. Okay. And just to get your brain thinking, we had discussed another antiviral drug that had significant psychiatric side effects. Do you remember that other antiviral drug that had significant psychiatric side effects? That was interferon. And that sometimes we just had to stop interferon therapy because it exacerbated underlying psychiatric illness and can cause such severe depression. Same thing with efavirenz. Etravirine is the first of the second generation NNRTIs. Etravirine may retain activity against HIV strains resistant to first-generation NNRTIs. So this was a big problem. One of the reasons that we wouldn't want to start an NNRTI in someone who was just beginning therapy, someone who is treatment naive. So their first regimen, we were hesitant to give efavirenz because if they weren't as compliant as they should be and they got a mutation to efavirenz, it could rule out that whole class and they wouldn't be able to use them again. But now this second generation NNRTI has been developed and appears that it can retain activity against those HIV strains that do become resistant to the first generation NNRTIs. So that's a good development as well. Etravirine does have good oral bioavailability, and that's enhanced with a high-fat meal. It has a long half-life of 40 hours, but for now it's still indicated for twice daily dosing. It's extensively metabolized and is an inducer of cytochrome P450. The most common side effect is rash. It does not have the serious CNS side effects that we see with efavirenz, and it is a pregnancy class B medication, unlike efavirenz. It's currently indicated for treatment-experienced HIV patients and not as part of a first-line regimen. What we often see with new HIV drugs is that when they first come onto the market, their indication is for treatment-experienced HIV patients. So those are HIV patients that have probably been on antiretrovirals for a while and have multiple mutations built up and who are experiencing a measurable viral replication even in the presence of a good antiretroviral regimen. And so in those patients, that's where a lot of the trials for the new HIV medications occur. And so when these new HIV medications come on the market, what you'll often see is that they're indicated for treatment-experienced people who have ongoing viral replication despite a antiretroviral regimen that's been formed just for them based on their genotype. And so that's probably what we're seeing here with etravirine as well. Now, protease inhibitors. Let's leave the NNRTIs behind, and then we'll move on to the next class of antiretrovirals, and these are the protease inhibitors. All protease inhibitors are reversible inhibitors of the HIV aspartyl protease, which is an enzyme that's responsible for cleaving the polyprotein into multiple different enzymes and structural proteins that are necessary for viral functions. Protease inhibitors show a greater than 1,000-fold affinity for HIV protease as compared to its affinity for human protease, which allows them to really selectively target HIV. Protease inhibitors block the maturation of viral particles and thereby limit their infectivity. Protease-based therapy in treatment-naive patients. Treatment-naive, like I mentioned before, means that they haven't had HIV therapy before, and so they're naive to HIV therapy. So protease-based therapy in treatment-naive patients have a complete response in up to 95% of cases. And a complete response means that undetectable viral load, or a viral load of less than 50 copies per milliliter. And so that's what I was talking about when I was talking about the potency of a protease inhibitor-based regimen. And that's what we're used to seeing, is up to 95% of people really getting a good response when they are initiated on a protease inhibitor-based regimen. Now let's talk about the pharmacokinetics of protease inhibitors. Protease inhibitors as a class have poor oral bioavailability with a highly variable response to high-fat food. All of them are substrates for the CTP3A4 enzyme and may be a substrate for other cytochrome P450 enzymes as well. So metabolism is extensive and dose adjustments for renal function are unnecessary. Protease inhibitors are also substrates for P-glycoprotein multidrug efflux pump, which may limit access of PIs to the CNS. PIs are also protease inhibitors, so if I use them interchangeably, I'm sorry. Protease inhibitors bind extensively to plasma proteins, especially to alpha-1 acid glycoprotein, which increases after surgery or trauma. So you can see how this would cause some interactions with your protease inhibitors and with the plasma concentrations possibly of the free drug, and could lead to complications. Now, adverse effects of protease inhibitors. Protease inhibitors will commonly cause paresthesias, nausea, vomiting, and diarrhea. Metabolic disturbances can also occur, and this can lead to elevated lipids and glucose abnormalities. Physical changes include fat redistribution and can be an outward sign of that antiretroviral treatment and can be stigmatizing, as we discussed earlier in this lecture. Drug interactions are common problems for people taking protease inhibitors because protease inhibitors are both a substrate and inhibitors of the CYP isozymes. Drug interactions are frequent and can be very dangerous, especially in medications that cause sedation, respiratory depression, or anticoagulation. Other drugs that induce or inhibit CYP isozymes may also affect protease inhibitor concentrations. So it's very important to keep an eye on the medication list of HIV patients. Always have them bring you their entire list of medications because you can rest assured there's going to be drug-drug interactions to deal with if they're on protease inhibitors. And you need to keep in mind any other drugs that are metabolized to the cytochrome P450 system. Now let's discuss resistance. Mutations can slowly accrue within the HIV genome that allow it to evade the effects of protease inhibitors. And subtherapeutic concentrations allow this process to occur much more quickly. And so patient education is an extremely important part of antiretroviral therapy. And I alluded to this at the beginning of this lecture, saying that when patients start antiretroviral therapy, they need to really know that compliance is a huge part of the durability of their therapy, that the effects of therapy, in order to be sustained over a lifetime, rely on the patient being very compliant with their medication. And like we've said in other lectures, when you're talking about long-term therapy, and in this case we're talking about everyday therapy for the rest of their life, that's a lot to ask from a patient. And so we have to make sure that they're educated and well prepared to start this process before it actually begins. And again, and we see this with protease inhibitors, that if a person misses their medication or takes it at the wrong time, that you can see subtherapeutic concentrations in the plasma, and these subtherapeutic concentrations can then allow viral mutations to accrue more rapidly, and so we get this viral resistance occurring faster in patients who have subtherapeutic levels, which often occur as a result of noncompliance. Okay, now let's talk about the protease inhibitors individually, and we'll begin our discussion with the agent ritonavir. Ritonavir is not used as a single agent any longer. It was originally introduced that way, but it's no longer used that way. It is used to boost other protease inhibitors, and it's called that. Boosted regimens are ones that include ritonavir along with another active protease inhibitors. Because ritonavir is a potent inhibitor of CYP3A4, ritonavir increases the plasma concentrations of other protease inhibitors and can increase their dosing interval. Increased concentrations also appear to help minimize the development of resistance. And so this ritonavir can increase concentrations in the plasma, and it can lengthen the dosing interval. So with these characteristics, it's very helpful to use it in conjunction with our other protease inhibitors. First-line treatment options in the national guidelines only include boosted PI regimens. And so those are regimens that include an active protease inhibitor along with a small dose of ritonavir. Ritonavir relies on metabolism and biliary excretion for elimination, and the half-life is about 3 to 5 hours. Because it is a substrate of CYP3A4, it can be affected by other drugs. Nausea, vomiting, diarrhea, headache, perioral paresthesias are all common adverse effects for ritonavir. Now let's move on from ritonavir to saquinavir. Saquinavir is administered in a boosted format with ritonavir. High-fat meals can increase absorption, and saquinavir should be taken with a full meal. Saquinavir undergoes metabolism and biliary excretion. It has a half-life of about 7 to 12 hours, which necessitates multiple doses per day. Drugs that induce metabolism, such as rifampin, rifabutin, nevirapine, efavirenz, or any other enzyme inducer, should be avoided if possible. The most common side effects that we see with saquinavir include nausea, vomiting, diarrhea, headache, and fatigue. Saquinavir may also elevate liver enzymes, especially when co-infected with hepatitis B or hepatitis C. Moving along to our next protease inhibitor is indinavir. Indinavir is well absorbed orally. It's the protease inhibitor that has the least protein binding at about 60%. Indinavir absorption is decreased when taken with food, and ritonavir can help overcome this limitation with indinavir. Metabolism and hepatic clearance account for most of the elimination of indinavir, so dose adjustment is necessary for hepatic insufficiency. It has a short half-life of about 1.8 hours. It is generally well tolerated with the usual protease inhibitor side effects of headache, nausea, vomiting, and diarrhea predominating. Indinavir characteristically causes nephrolithiasis. And again, this is a common test question, so remember the link, the association between indinavir therapy and nephrolithiasis. And so patients who are on indinavir need to drink at least 48 ounces of water a day. That's the recommended, so that they can stay very hydrated, and this will help overcome that side effect of nephrolithiasis. Hyperbilirubinemia and fat redistribution are also problematic with indinavir. Now let's move on to the next agent, nelfinavir. Nelfinavir is a non-peptide protease inhibitor. It's well absorbed without strict dietary restrictions, but it is usually taken with food. It's metabolized by several CYP enzymes. It is not adequately boosted by ritonavir, which relies on inhibition of the CYP3A4 isozyme alone. One major metabolite of nelfinavir has activity as great as the parent compound, and so the metabolites can be active here, but they're usually in lesser concentration. The half-life is about 5 hours, and diarrhea is the most common side effect that we see with nelfinavir, and since it's common and persistent, we often just treat it with antimotility agents like loperamide. Nelfinavir may interact with many other drugs, and this just mandates a thorough review of their medications like you should do with any of these protease inhibitors. Let's move on to the next agent now, and that's fosamprenavir. You may notice as we go through these that every one of these protease inhibitors ends with avir. And so that could be one clue on your test that it belongs to the protease inhibitor class if it's nelfinavir, indinavir, sequinavir, fosamprenavir, or lopinavir, that these are all protease inhibitors. Fosamprenavir is a prodrug that's metabolized to the protease inhibitor amprenavir. It has a long plasma half-life that allows twice-daily dosing. Fosamprenavir can be boosted with ritonavir and is recommended as a first-line agent in national guidelines. Common adverse effects include headache, nausea, vomiting, diarrhea, paresthesias, and fatigue. And like other protease inhibitors, fosamprenavir is a substrate of the cytochrome P450 system and may lead to significant drug-drug interactions, so vigilant oversight is required. And now lopinavir, ritonavir. And they're listed as lopinavir, ritonavir because lopinavir is co-formulated with ritonavir and is only marketed that way. So you'll see them together. It is a peptidomimetic. It's a peptidomimetic protease inhibitor. It's one of the first-line agents for treatment of HIV in national guidelines. It has poor oral bioavailability, but that is enhanced with the addition of ritonavir. GI symptoms and hyperlipidemia are common side effects in addition to the class effects for other protease inhibitors. Like other protease inhibitors, lopinavir can inhibit metabolic enzymes, and this will raise plasma concentrations of other drugs that are metabolized through those same systems. Likewise, enzyme inducers as well as St. John's wort should be avoided when using lopinavir, as plasma concentrations could be subtherapeutic. The oral solution that contains lopinavir contains alcohol. And this is just something good to remember because you could have symptoms, a disulfiram-like reaction if that is given in combination with a medication like metronidazole or with actual disulfiram or antabuse. Let's move on to the next protease inhibitor, and that's atazanavir. Atazanavir is a protease inhibitor that's structurally unrelated to other protease inhibitors. Boosted atazanavir is a recommended first-line agent, and it's the only recommended protease with once-daily dosing. And so this has been a real boon as well to the HIV field, having a once daily dosed protease inhibitor. It's well absorbed orally and has increased absorption and bioavailability when given with food. It's highly protein bound at about 86%. It does undergo extensive metabolism by the CYP3A4 isozyme and is excreted into the bile. The half-life is about 7 hours. It's a competitive inhibitor of glucuronyltransferase, which results in a benign hyperbilirubinemia and jaundice. This is an important side effect to remember about atazanavir, and one that may show up on a test is one that we encounter regularly in the clinic. Atazanavir causes a lot of elevated bilirubin and frank jaundice, and this is one of the complaints that patients have. They love having once daily dosing of their HIV medicines, but they don't like yellow eyes, and so this limits its utility sometimes. Most of the time we get patients to just kind of tolerate the side effects because it is such a good medicine, but it is something that's characteristically associated with atazanavir, so a good thing to remember. Atazanavir does appear to cause less hyperlipidemia and glucose intolerance than other protease inhibitors. And this again is a huge benefit, because what we see with other protease inhibitors that we can have sky-high lipids that all of a sudden they will get dangerous levels of hyperlipidemia. And then in order to treat them, we would usually use a statin, but there's so many drug interactions that we frequently can't use the statins that we want to, or the statin that we want to use won't be covered on that patient's insurance, and it becomes really tricky to deal with all the problems surrounding the hyperlipidemia as well as the glucose intolerance. And so to have the option of a protease inhibitor that doesn't have a significant effect on their lipids is a really welcome addition. And so it's great to have atazanavir in the armamentarium. Of note, atazanavir can prolong the PR interval and slow the heart rate. Atazanavir is a significant inhibitor of the CYP3A4, and this sets the stage for many drug-drug interactions. Atazanavir should not be used with proton pump inhibitors and shouldn't be used within 12 hours of H2 blockers and antacids. All right, let's move along to the next agent, tipranavir. Tipranavir is an HIV protease inhibitor without much overlapping resistance from other protease mutations. And so that's an important characteristic of tipranavir is little overlapping resistance. It's well absorbed when taken with food. It has a half-life of about 6 hours, and so it needs to be taken twice daily and boosted with ritonavir. Tipranavir acts as a substrate and an inducer of cytochrome P450. And it's an inducer of cytochrome P450 that's unique amongst the protease inhibitors and can result in different drug reactions than you see with other protease inhibitors. So you just have to be aware of that. Protease class side effects occur with tipranavir. In addition to those class side effects, there are 2 black box warnings. There's severe and fatal hepatitis that can occur, as well as fatal and non-fatal intracranial hemorrhage that can occur with tipranavir. Most patients that had these severe reactions did have underlying comorbidities, but it's still something to be concerned about. Tipranavir currently is indicated for the treatment of antiretroviral experienced patients who have multiple drug resistances. Okay, let's move along to darunavir. Darunavir is a recently approved protease inhibitor that is active against some HIV isolates that are resistant to other protease inhibitors. It's well absorbed when given with food. It has a terminal elimination half-life of about 15 hours when it's combined with ritonavir. It is both a substrate and an inhibitor of CYP3A enzymes, and it has similar side effects as other protease inhibitors with the addition of rash. So we see rash more with darunavir than we do with some of the other protease inhibitors. It does have a sulfonamide moiety, and so it is something you have to remember when you've got sulfa-allergic patients. It may also have less impact on the lipid profile than we see with some of the other protease inhibitors, but they're still trying to work out all of its metabolic effects through long-term studies. It is indicated for the use in treatment-naive and treatment-experienced HIV patients. It has gained the indication for treatment in treatment-naive HIV patients. All right, that completes the protease inhibitor section, so let's move along to the entry inhibitors. Let's begin with enfuvirtide. Enfuvirtide is a fusion inhibitor. It's the first in the class of entry inhibitors. For HIV to infect a cell, the membrane of the virion must fuse with that of the host cell, and this is mediated by a conformational change of the viral transmembrane glycoprotein GP41. And so enfuvirtide binds to GP41, and this inhibits that conformational change. And so you can see by inhibiting the conformational change, then it inhibits the entry of the HIV into the host cell. It is approved for use in treatment-experienced patients who have evidence of ongoing viral replication despite continued antiretroviral treatment. Enfuvirtide is a peptide, and so it must be reconstituted and then administered subcutaneously. So it's a little burdensome to take this medication. Burdensome and expensive, I must say. It has many side effects, many of which are related to the subcutaneous administration. This includes pain, erythema, induration, and nodules. This occurs in nearly every user that uses enfuvirtide, but really only about 3% discontinue use for this reason. So they can tolerate it, but it's bothersome, to say the least. You know, these patients who are on enfuvirtide usually have multiple resistances in their genotype, and they're on what's called salvage therapy, and so we're just kind of throwing everything in the kitchen sink at them. And so enfuvirtide does have some activity in these salvage regimens, and so many of them will continue this therapy even in the face of all these side effects, because it's really kind of their last-ditch attempt to keep that HIV infection under control. Enfuvirtide is very expensive, and like I said, it's burdensome to one's lifestyle. Maraviroc is the second entry inhibitor. It blocks the CCR5 receptor that works with the GP120 protein to allow entry of HIV into the host cell. So HIV in general can express a receptor for CCR5, it can express a receptor for CXCR4, or it can express both. Or you may have populations that of HIV that express one or the other. Maraviroc inhibits only the CCR5 expressing HIV populations. And so before you begin this therapy, you have to perform a test on the HIV virus to see to determine tropism of that infecting virus, to see which of these co-receptors is present, because Maraviroc will only work if it's a only CCR5 expressing HIV infection. Maraviroc is metabolized by the cytochrome P450 enzymes, and therefore drug-drug interactions can be problematic, and the dose should be adjusted when it's co-administered with protease inhibitors. But in general, it is well tolerated. And finally, let's talk about the integrase inhibitor, raltegravir. Raltegravir is the first of a new class of antiretroviral agents called integrase inhibitors. Raltegravir inhibits the final step of integration of that viral DNA into the hosts. The half-life is about 9 hours, and so it is dosed twice daily. It's metabolized through glucuronidation. There is no metabolism through the cytochrome P450 system, and so there are few drug-drug interactions that you need to be concerned about with raltegravir. It is generally well tolerated, but common side effects include nausea, diarrhea, and headache. And that completes your lecture on the antivirals used to treat HIV infection.
We're back again to play Name That Drug. What drug can cause the following reactions? Rash, fever, pharyngitis and cough, diarrhea. Time's up. How did you do? The correct answer is abacavir. The use of nucleoside drugs such as abacavir can also very rarely cause lactic acidosis. Thanks for playing Name That Drug.
All right, let's go through the answers to quick review number 2. Number 1, which NNRTI can have CNS side effects. This is important to know. It is efavirenz. So it was recommended that patients with psychiatric ailments such as depression should not go on efavirenz. Definitely know that it can cause CNS side effects and can exacerbate any psychiatric comorbidities. Number 2, which HIV antiviral drug can cause a false positive in some urine tests for marijuana? This also is efavirenz. So efavirenz, you can think of it, it's not marijuana, but it causes a false positive for marijuana and it causes CNS side effects. So it's kind of easy to remember efavirenz having those effects because of that association. Number 3, what are the adverse effects associated with protease inhibitors as a class? So they can cause GI upset, including nausea, vomiting, and diarrhea. They can cause hyperglycemia and hyperlipidemia. So as a class, they're not great drugs to use in diabetic patients. They cause paresthesias, particularly oral paresthesias. They can cause fat redistribution, and they can also inhibit cytochrome P450. Number 4, which antiviral drug is associated with nephrolithiasis or kidney stones? This is important to know. It's indinavir. Number 5, which protease inhibitor is known for causing hyperbilirubinemia? It is atazanavir. Atazanavir is the answer to this one. Number 6, there are 2 main phenotypes of HIV virus, X4 and R5. So this was kind of alluded to earlier, but we're going to clarify exactly here what those are. Early in the course of HIV disease, the most prominent phenotype is R5, which indicates that this phenotype binds CCR5 on CD4 cells. Later in the course of HIV infection, more and more of the X4 phenotype is found, which indicates that this phenotype binds CXCR4 on CD4 cells. What HIV antiviral is used predominantly early in the disease against the R5 phenotype, because that's the one we find early in disease, because it binds to CCR5, preventing fusion and entry of the virus into the host cell. Maraviroc is the drug that does this. So that's also important to know. Number 7, which anti-HIV drug is the traditional go-to drug for HIV and pregnancy? So zidovudine, if you see this on a test, HIV drug and pregnancy, and you're given a list of options, go with zidovudine, because that's the HIV drug that we've used in pregnancy for the longest period of time. However, there are other safe drugs that we use now in pregnancy as well. These include lamivudine, lopinavir, and rotenavir in combination. It's the lopinavir plus ritonavir boost. Nivaripine is another drug. And the last one is etravirine. So that's it for this quick review. Let's head to your in-session quiz.
All right, let's go over the answers to your end-of-session quiz. First question, what are the drug components of a typical HAART, or H-A-A-R-T regimen, the highly active antiretroviral therapy regimen? Well, the 2 components are you use 2 NRTIs, that's your NRTI backbone, and then you use either one NNRTI or one protease inhibitor. So 3 drugs, 2 NRTIs, and either one NNRTI or one protease inhibitor. Next question. Match the following mechanisms of action with the associated drugs. So the first one, incorporated into viral DNA, terminating DNA elongation. This is the definition of an NRTI, nucleoside or nucleotide reverse transcriptase inhibitor. And the one listed there is didanosine. The next one, protease inhibitor. This is sequinavir. Remember, all the protease inhibitors end with avir. So sequinavir is the only one on that list that's a candidate. Next one, viral entry inhibitor. Now, there are only 2 viral entry inhibitors, enfuvirtide and maraviroc. And the answer in this case is enfuvirtide. And the last one, non-competitive reverse transcriptase inhibitor. This is an NNRTI, and that's efavirenz. Next question. Match the following drug to the correct antiviral class or description. So we have indinavir. Remember, avir, that's a protease inhibitor. Zidovudine. Zidovudine is an NRTI. It was the first NRTI. Remember, NRTI can stand for nucleotide reverse transcriptase inhibitor or nucleoside reverse transcriptase inhibitor. Which one is zidovudine? It's a nucleoside reverse transcriptase inhibitor. The next one is raltegravir. This is the integrase inhibitor. It's the only integrase inhibitor there is. Next one, nevirapine. This is an NNRTI. And the last one is Maraviroc. We mentioned this earlier. This is a viral entry inhibitor. Next question. What are the two HIV envelope proteins and the drugs that interfere with them? So there are two proteins here on the HIV, on the virus. They're envelope glycoprotein 120, or GP120, and then glycoprotein 41. And then there are two drugs that interact with each of these. The two drugs are Maraviroc, which interacts with GP120. Specifically, Maraviroc binds to the CCR5 receptor on the host cell, on the CD4 cell, and that CCR5 receptor normally interacts with GP120. So if you block the receptor, it won't be able to interact with the GP120 on the HIV, and the HIV won't be able to enter the cell. The other drug is Enfuvirtide, which binds to not the receptor on the host cell, but it binds to the protein on HIV. It binds to glycoprotein 41, and therefore it inhibits that glycoprotein from undergoing the conformational change that allows the HIV virus to get into the host cell. Next question. Classify the following HIV/AIDS drugs, and you see there's a list of all 23 drugs. It's really important to be able to recognize each of these drugs and to know what class they fall in and how they work. So the first of these are the NRTIs. So you see there's a list of all 23 drugs, and you really need to be able to recognize which drug is a member of which class and how these drugs work. So first, the NRTIs. These include abacavir, didanosine, emtricitabine, lamivudine, stavudine, tenofovir, and zadovudine. The integridase inhibitor is raltegravir. Now be careful, we've already said that all the protease inhibitors end in avir, which is true, but this drug also ends in avir, and it's not a protease inhibitor, it's an integrase inhibitor. There's one other drug in this list that also ends with avir, but is not a protease inhibitor. Which one is that? It's abacavir. It's an NRTI, which we just saw. Next group are the protease inhibitors, atazanavir, darunavir, fosamprenavir, indinavir, lopinavir, nelfinavir, ritonavir, sequinavir, and tipranavir. Next group are the entry inhibitors. We've already mentioned these, Enfuvirtide and Maraviroc. And then NNRTIs, delavirdine, efavirenz, nevirapine, and etravirine. Next question. What are the adverse effects that are associated with raltegravir? Well, raltegravir is generally well tolerated, but it can cause some nausea, some headache, and some dizziness. And it also can cause an unfavorable lipid profile. Specifically, it can raise your LDL, your bad cholesterol. It can raise your triglycerides. Now remember, protease inhibitors often do this as well. So raltegravir can do this. Next question. Which antiretroviral or antiretroviral class matches the following statement? So basically, we have a list of side effects here. So the first one is lactic acidosis. Remember, Dr. Schufer talked about lactic acidosis being related to hepatotoxicity. Well, which drugs typically cause hepatotoxicity? The NRTIs, except for abacavir. The next one, GI intolerance, hyperglycemia, and lipid abnormalities. We just mentioned that protease inhibitors cause lipid abnormalities, and they also cause GI intolerance and the hyperglycemia. When we talk about GI intolerance with protease inhibitors, we're talking about nausea and vomiting and diarrhea. Next one, pancreatitis. This is typically a problem with NRTIs, especially didanosine, zalcitabine, and stavudine. The next one, peripheral neuropathy, also a problem with NRTIs, the same drugs, didanosine, zalcitabine, and stavudine. The next one, aplastic anemia and granulocytopenia. This is basically talking about bone marrow suppression. The drug that typically causes bone marrow suppression, zadovudine. And then finally, rash. Now there are three drugs I want you to remember for rash, or three groups of drugs. The first one, NNRTIs. Nevirapine can cause Stevens-Johnson syndrome and toxic epidermal necrolysis, or TEN. These are both very severe, potentially life-threatening problems. Other NNRTI drugs can cause a more mild or less severe rash. The other two drugs that can cause rash, abacavir. Remember, Dr. Schufer talked about the hypersensitivity of abacavir. Hypersensitivity of abacavir involves drug fever plus one of the following four symptoms: rash, GI problems, malaise, or respiratory distress. So if you have a patient with rash and also has drug fever, that could be hypersensitivity of abacavir. And then the third drug that can cause rash is darunavir. It's one of the protease inhibitors. Next question. Why would lopinavir and ritonavir, two protease inhibitors, be used in combination? Well, this is an example of a boosted regimen. Remember, lopinavir is only sold in combination with ritonavir. Ritonavir inhibits cytochrome P450, and this decreases the metabolism of other protease inhibitors. This prolongs the therapeutic levels of lopinavir, so you can have less frequent dosing, you can have better compliance, and therefore less resistance. So again, this is a boosted regimen. Next question, which antiretroviral matches the following statement? So we're going to go back to more side effects. First one, CNS changes, very common with efavirenz. Hyperbilirubinemia, and also jaundice. Remember Dr. Schuford said this was a benign but very common side effect of atazanavir. So unlike other protease inhibitors, atazanavir doesn't affect lipids. So even though the patients are complaining about the jaundice, you try to stick with it if you can, because it will help with their HIV and also not cause problems with their lipids. And then finally, nephrolithiasis is a complication of indinavir. And remember Dr. Schuford said patients need to drink at least 48 ounces of water daily to help prevent nephrolithiasis. Next question. What is the most important determinant of whether or not a heart regimen will be successful? Well, the most important determinant is patient compliance. Even missing 1 or 2 doses of medication a week can have a dramatic effect on development of resistance to the drug regimen. So you really have to counsel your patients and help find any way to overcome the obstacles to good compliance with these drugs. That's the end of your end session quiz.